to our northernmost station in Riley County.
When a 911 call comes in from Leonardville, Kansas, it's close to a 30-minute drive to the nearest emergency room.
We have to worry more about whether the patient deteriorates going from, a 30, 40-minute transport time versus a 4 or 5-minute transport time.
But transport time is just one factor that complicates rural health care in the United States. Nearly 90% of the land in the U.S. is rural. That can be defined by population, road ruggedness, or commuting distance to the nearest big city. And these areas are home to 1 in 5 Americans, many of them older and with fewer resources. That's some 60 million people, according to the U.S. Census. But there are only about 2,000 rural hospitals in America. And over 40% of them operate at a loss, according to the Chartis Center for Rural Health, a healthcare analytics and consulting firm. Each circle here represents the number of rural hospitals in each state. The bigger the circle, the more there are. Now, let's look at risk. The darker the color, the higher the percentage of rural hospitals in each state are at risk of shutting down. The threat of closure looms especially heavy in the darker shaded areas of the Midwest and South. For example, in Kansas, nearly half of all rural hospitals are at risk.
Rural hospitals save lives. There is no question about that. Closing of rural hospitals will jeopardize people's lives every day in the state of Kansas.
Reuters set out to understand what makes these hospitals, vital to rural Americans, so vulnerable to closure. This is Holton Community Hospital. Facilities like this one have to do a balancing act. There are high fixed costs when providing broad emergency coverage.
If we were to not be here for our community, people would be driving over an hour, could be to Kansas City, that's an hour and a half to receive those specialty services.
But there can also be low patient volume, and that limits revenue. Affording specialists can also be out of reach, which means some patients have to travel anyway. Often, obstetrics and gynecology services are the first to go when funding doesn't come through, like here in Coffee County Hospital.
Moms now have to travel for labor and delivery. To no longer have that labor and delivery piece, it's tough.
So, where does the funding come from? Rural areas across the country rely heavily on Medicaid and Medicare relative to the size of their populations. Medicaid is a federal program that provides health insurance to more than 70 million poor children, pregnant women, seniors, and people with disabilities. And Medicare is the government health insurance program for people over 65 and for those with certain disabilities or medical conditions. When patients have health insurance, hospitals are reimbursed more reliably for the care they provide. It's not straightforward, though, because the finances of small community healthcare are tied to lots of different Medicare reimbursement classifications. Most rural hospitals are classified as critical access hospitals and are reimbursed based on the cost of services. Then there are rural emergency hospitals. This is a designation that provides federal funding for facilities that shutter more expensive inpatient care and focus on outpatient care instead. Since 2005, over 80 rural hospitals have shuttered inpatient care, and more than 100 have shut down entirely. There are many factors that contribute to financial vulnerability. Experts told Reuters that one important predictor for a rural hospital's health is the ratio of inpatient revenue relative to outpatient. Most rural hospitals rely on outpatient care to stay afloat, but fewer inpatient services means smaller billings.
If Medicare cut back anymore, I was chief of staff, co-chief of staff for a year, and I saw the numbers. A lot of hospitals are closing because they can't make it.
Adding to the challenges, Republicans' July 2025 budget reconciliation bill included nearly $1 trillion in cuts to Medicaid. Those cuts and some other measures will leave about 10 million people uninsured by 2034, according to estimates from the Congressional Budget Office. White House spokesman Kush Desai said rural hospitals struggled with low usage and increased Medicaid spending in the past had not helped.
They'll buy their own health care.
Desai said the Trump administration's $50 billion Rural Health Transformation Fund would push states to adopt meaningful health care reform that can actually make rural hospitals economically viable again. But were rural hospitals ever economically viable? Let's take a look back. Medicare and Medicaid launched in 1966. They were part of President Lyndon B. Johnson's Great Society programs aimed at ending poverty and racial injustice. More than 19 million Americans signed up for Medicare that first year, and it provided a base of stable funding for rural hospitals for the first time.
To make their health care more affordable.
Then, President Obama's Affordable Care Act, or ACA, signed into law in 2010, expanded eligibility for Medicaid. It also created a health insurance marketplace with more government-subsidized coverage. 40 states opted into the expansion over a decade. With more Americans insured, rural hospitals were being compensated for more care. The result? Revenue increased, bad debt dwindled, and margins improved. Being an expansion state is one of the indicators that data scientists at the Chartis Center see as a protective factor. But addressing social issues at the federal level is deeply polarizing in the United States. Republicans argue that the ACA moved Medicaid too far from its original intent by loosening eligibility requirements. Stricter conditions in Trump's Big Beautiful Bill will start January 2027. That's 2 months after midterm elections. Any loss in payments would erode margins that are already thin or non-existent. And southern and central states, which have the largest number of rural hospitals, are more likely to vote Republican and less likely to expand Medicaid. Beyond Medicare and Medicaid payments, there are other funds available for rural healthcare providers to stay afloat. County or city tax support, contributions from foundations or philanthropy, and regional corporate donors. Holton County asked its taxpayers to contribute.
Our community did really step up in regards to the bond issue, a quarter tax, which has made a huge difference for our community. It will make a huge difference for our community, because I think any community that doesn't have a hospital is a community that will die.